Very good. Dr. Garza,
Here.
Bishop Hankerson,
Here.
Jeff Smith, of course, here.
Here.
Ms. Rios and Dr. McBride, both absent. Dr. Cunningham?
Here.
Thank you. We have a quorum.
All right. Hope everyone is doing well and staying relatively cool. Good to see people. I know Scott, you are not able to be in St. Louis today, and I hope things are going okay with your family stuff. I'm also unable to. I'm in St. Louis, but unable to be in. So I apologize for that. My wife is out of town. Why don't we go ahead and start by approving the March meeting minutes? I hope folks have had a chance to review them. And I would move for the approval of those minutes.
Second.
Okay. Is there any discussion about the minutes or any proposed revisions? Okay, hearing none. Penny?
Dr. Garza,
Aye.
Bishop Hankerson,
Aye.
Dr. Cunningham,
Aye.
Dr. Smith.
Aye.
Approved.
All right. Thank you all. All right. Scott, why don't we go ahead to the next agenda item, the Department of Mental Health partnership related to on-site competency evaluation.
All right, thank you, Jeff. So we are in partnership with Department of Public Health and are entering into an agreement with the State Department of Mental Health, which will allow us to have several staff from the State Department of Mental Health actually working in the jail, stationed there to provide counseling, therapy, medication, and expedite the competency assessments. So those have been taken over a year at the state level, and we're told that this will shorten that to 60 days. So we hope to have those staff in place by September 1st, and there also will be some compensation for the county for people that are in those beds. Those would have been people that would have been waiting for a bed in Fulton or at a center in St. Louis that does those competency assessments. So we're very excited about that. That legislation will be going through the council process for approval, and so that we already have a unit designated with some people with mental health needs that's in operation now, and are sending staff through training as well. And so, yeah, did I hear you starting to ask a question, Jeff?
So is it our staff that will do that or state staff?
The state employees will be on site working with public health staff and our staff, all in collaboration in the mental health unit, but the assessments are actually done by the state employees, as they would be.
And they're still going to compensate the county for housing people that they would have otherwise housed.
Yes.
In addition to, supplementing county employees with expertise and manpower. So that seems like a pretty good deal for the county.
It's a great pilot, and hopefully that will go well, and it'll be something that could be offered in other areas. And I have been working with them to try to establish this in the city as well. But we're the first to be rolling this out, and it should be a great way to shorten the time frame that some of these cases have been taking to assess competency or get them stabilized to a point that they can move through the legal process. Also, a lot of the medication is very expensive, and those costs will be paid by the state as well for those people. We still will have the mobile unit that's been in place, And Department of Public Health still be providing behavioral counseling and psychiatric services. Dr. Cunningham's on the call as well. And we traveled down to Houston along with people from the prosecutor's office, the CIT unit with the police department, and Public Works to visit a best practice diversion center site that's been highlighted nationally, and are working on a potential location. We shared that at the last advisory board meeting. So that process is well underway as well.
So how do those two items, how are they intertwined?
Well, so some of these cases could be deferred, and we have the mental health court, and the prosecutor's office has had some diversion for mental health cases. But right now we have an urgent care center in St. Louis County through SSM Healthcare, DePaul, where people can be taken by the police. But this center would expand the ability for police officers to bring people to a diversion center where they could then receive treatment and potentially be diverted entirely from coming to the jail. Also, it could be a possibility that they may need residential care, and if they needed emergency care, they could be taken to that SSM emergency care site. I do know there's plans for development of another one of those centers near St. Louis University as well. But that's a good step to try to divert people entirely from the jail. Even if they were charged, potentially they could be supervised out in the community pending their hearing. And the mental health unit is actually created to provide a unit where people can get behavioral health care treatment that they need while in a unit that they might have otherwise been in segregated housing, for example. So when people are admitted into the jail, we'll be looking at potentially, once that diversion center is set up, a process that they might still be taken to the diversion center if the prosecutor's office decides that they don't need to be charged. And if they are admitted into the jail, through a screening process at intake, will be determining if they need placement in a mental health unit. And we're also looking at people that are currently in segregated housing that could benefit from that type of a housing arrangement.
And how large, what are you projecting the capacity of a diversion center would be?
That's a good question. So that's a really good question, Jeff. I think the potential for that could be very high. I think that depends on a lot of different things. So I think we'll probably need to get back with you as that process moves forward, because the diversion center is just in the very beginning stages of planning.
Okay. And are you thinking, I know that that earlier this year I had connected you with a trustee from the Sidney Bear Foundation, which funds this sort of work and I think is interested potentially. Are you seeing this as like a mix of public and private funds? Do you have a sense from the county executive if there's interest in a significant infusion of county funds, just because I know how difficult the county budget is this year? And so I was just wanting to get, because this is going to cost a lot. Is this like an 8-figure expenditure, I would assume?
I do think that there's strong support for this, and that it's a possibility that it could benefit emergency rooms by diverting people from those emergency rooms where they might end up otherwise.
Mm-hmm.
So there could be support from the medical community, and also we're already seeing support from the state, the Department of Mental Health, in doing more in this space. And this involves collaboration of 5 different county agencies. So I would say yes to all those questions, Jeff.
Okay. And do you have a ballpark? Like, what's the capacity of the Houston Diversion Center?
They actually have expanded. So they didn't start with a large facility like they have now. They started very small, and then have expanded and built that center so that it. And I'll send you a link that will give you all the details about that center itself. But they're using it not only for jail diversion, but uh, for other community mental health care. So they have I think they have a release side to that center. They have a youth side. They have an emergency room side where they're diverting people as well. And then they have some beds just for general mental health care also. So it's a very large center, but they did start small. And in our case, we are not planning to have beds initially, but
Okay.
that's something that could be developed down the road.
Okay. Yeah, my main kind of questions. I'm sure other board members probably have questions more about the operations. My questions are kind of like initially, where will we get the stakeholder buy-in to get the funding to stand something like this up?
If you don't mind, can I jump in here?
Yes, absolutely.
So I would say in the community, there's actually it's like a unknown but known priority that a lot of people are interested in addressing behavioral health and substance use in a different manner. And so a lot of your more major metropolitan areas, they are moving into a collaborative diversion model. So I think it's multiple different things when we think about sustainability or initial budget. But I will say in a region locally, like this is a significant need. And Scott hit on a few things with diversion from the hospitals, but also, police will be able to spend more time with focusing on crime, because a lot of things that come up too, we don't think about the impact on the police department with, if it's truly behavioral health, if there's a spot or a space that they can take someone who can fully meet the needs. And it's the Virgin Center. It is a multi-collaboration. So we'll have additional resources available to assist with all of the social determinants of health. So this will be a new model for the region, but the benefit for the community that we should be serving is huge. And the fact that there's a priority among a lot of the major organizations to really strengthen the behavioral health network in the region. So, Jeff, I definitely understand your concern with that, but I think just with all of the interest around this, that there's grant funding available, there's multiple different funding sources that's available for this. And I will say there is, so far as Scott and myself have received a lot of positive feedback all across the board with truly developing something to meet the needs of the community. So I just want to put that in there, that definitely I understand your perspective and where it's coming from, but I also feel like Scott and myself have access to the resources and the interest to really be able to get this off the ground and again meet those needs for our community.
That's great. I mean, I love the concept, and I'm heartened to hear that there's broader stakeholder interest, and especially if like the hospital systems will step up with some money, then I think Alex, you're smirking just a tiny bit there. Do you want to weigh in?
Yeah, sorry, Jeff. Yeah, I chuckled a little bit because you obviously haven't seen the financials in the healthcare system lately. But but be that as it may, I know that Michelle Schaefer with SSM Behavioral Health has been working with Dr. Cunningham and Scott quite a bit on the diversion programs. Scott's right that we are going to be expanding down St. Louis University with our urgent care program. I think the key really for this is it's going to have to be a collaborative community approach. Like no one organization is going to be able to shoulder the whole thing. So, and I think that's what Dr. Cunningham and Scott have in mind as well. So.
Okay, cool. Bishop Hankerson, any thoughts?
No, sir, not at this particular time, but sounds great to me. Thank you, sir.
All right. Thank you, Scott. do you want to go into the next? Why don't we go to the next agenda item and get a staffing update, which I'm curious about since it's been a couple months.
Yeah, so some more great news. We had 15 officers that just completed OJT. We have another 8 that started OJT on Monday of this week. And last week we interviewed 25 applicants. 15 of those are starting on Monday. We had 25 interview or apply rather for interviews yesterday, and I think there were 15 that actually were interviewed from that group. And then we have about 40 that are scheduled to interview next Thursday. So I'm anticipating that within just a few weeks, we will have filled all the vacancies that we have. And you can imagine with this number of new officers coming in that we would have to expand new officer training, which we're prepared to do. And so hopefully by September 1st, be in a position where we can begin to discuss renewing the federal contract. We have initiated that process already. And as you can imagine, when you have more staff, the overtime levels will reduce, and we've seen that. I think you'll see that in charts. Overtime's already been reduced by 50% since just a year ago.
So did you say you're in negotiations about bringing federal detainees back?
Yes.
And at the higher rate, much higher rate than the state reimbursement, right?
Yes. Yeah. So we are
right now. Are they dispersed from? They're like some in like Kentucky and some in like Illinois. Are they still all over the kind of region?
Yes, they are. They're traveling. My understanding is that they're traveling a long way to bring them back for court hearings. And so I think that's a win-win for everyone, and we should be in a position to be able to do that soon.
Yeah, I mean, definitely a win for detainees and their families. As long as we have the capacity, a win for us financially to have that as part of our revenue mix. And you feel now totally confident that we're not gonna, slide back to where we were before, where we were so overwhelmed when you got here?
Yeah, there were 84 vacancies when I started, and I'm very happy to share that I believe we'll have filled all of those vacancies by the end of August.
That's great. That's really good news. Yeah, I mean, I know your vision when you first got a sense of the, you knew obviously the finances, for federal detainees. And I know part of your vision was that we can provide much more comprehensive services broadly if we have them as part of our revenue mix. And so we have to spend some money staffing up in order to, have the capacity to house those detainees. And so it sounds like that's come to fruition about like on the timeline that you hoped that it would.
Yes, that's right. And so through our recruitment efforts for incentives for veterans, they can receive up to a 1-year housing allowance. We already have officers that have received college credit through completion of the apprenticeship through Department of Labor. And
hey, do you have a graduation coming? Someone just is about to get an associate's degree. Is that right?
Yes, that's right. So any of the board members that would like to stick around or come in today at 1 p.m., there'll be an associate's degree presented by the president of Florissant Valley campus for St. Louis Community College to one of our attendees. And there's a class that's finishing up their classes. And so there'll be a big celebration today. And that's the third cohort of classes that have come through. So this individual had some credit already, but we'll be receiving that degree today.
That is so exciting. That's really great. This is probably a really stupid question, but kids cannot come in any way to the facility, right?
Right now, that's they're not able to come to the graduation. And
Okay.
we have had some discussions with Department of Social Service about a parent visitation program.
Yeah.
We're working toward that.
Okay. Okay. Good. I just know how inspiring, that kind of thing can be for a child to see, a triumph in their parents' life like that. So that's great. That's good to hear. Any other questions or feedback on that? So is there anything like more broadly? I know that can you I'm interested more broadly in staffing, not just at the CO level, but some of the changes that were recommended by the consultants last year. I'm wondering if you can speak to staffing more broadly, because we were, part of their assessment was that we were a little top heavy, and that was affecting, adversely affecting our ability to protect people on and operate effectively on the front lines. And I'm wondering if you could just give us kind of like, I would love to see just kind of like an org chart of like, not right now, obviously, of like where we are, which I think is fairly different from where we were a year or so ago.
Yeah. Yeah. So CGL had recommended that we reduce our number of majors from 6 to 3. And we have done that through attrition and retirement. We also have reduced our sergeant positions. The recommendation was to eliminate those. We do still have just a few sergeants that were already in that class, but those were to be fully eliminated, and lieutenant positions be increased, which we have done. We have added staff to our infirmary as was recommended. So there were not all reductions. Some of it was reallocation of staff, and at this point other than just those few sergeants remaining, we have fully implemented those recommendations. And the area that we are working on now are adding additional officers, because CGL had said that we were 82 officers. We were funded 82 officers less than we needed. And so in the budget for this year, there were an additional 16 officers that were approved, and we're making that request soon to the county council that we have through our budget process, that we would add additional officers. The plan was to phase that in over a 4-year period, just because of the financial cost of doing that, but there still is a need for additional officers.
Are you able to speak to staffing on the health side, or?
I really am not. I'm not knowledgeable about that, and so I wouldn't want to do that. The medical services are all provided by Department of Public Health, and
Right.
I know from our side, there have been just tremendous improvements under Dr. Cunningham's leadership, and we're collaborating, working on the mental health unit, and diversion center is just one example. We have plans to create a medicated assisted treatment unit also, as we're bringing in those additional staff, and that will allow us to provide substance abuse treatment just to everyone in a residential setting and within that unit, which would be another great collaborative effort. And we're doing some mutual training geared around mental health, and so really, really happy to see the advances that have been made. And I do know that there have been significant improvements there with recruitment on their end as well.
Dr. Cunningham, are you able to give us an update on that?
I can. Yeah, I can do that. I didn't know if I was able to do that on this board meeting, but I'm happy to give updates. So we are, as Scott said, that we're actually doing pretty good with our recruitment. So I have a new position, director of nursing. She started in April, and that's a brand new position for corrections medicine. She is phenomenal. She's a previous BJC nurse who thankfully wanted to come over and work with us from the jail. But she's doing absolutely amazing with recruiting nurse managers, as well as recruiting DPH nurses. So when I started, of course, we had a little bit more contracted staff, and I understand and at that time what was taking place, but I do have an interest of trying to reduce our reliance on contractors and move to DPH employment. And so that's kind of the mission and the messages. And of course, a lot of the contractor staff, they're absolutely fabulous. I don't want to give the impression that we having issues. It's just a budgetary decision and concern. So we're also we've hired quite a few medical assistants on the behavioral health side. I have a MAT manager right now, as well as a MAT discharge planner. And then we've also embedded 3 community health workers at the jail. So we still do have a few vacancies, just to be completely honest, but we have definitely done significantly well with our recruitment at the jail. Also, just for update, our medical director, that was a contracted physician. She's no longer with us, and we have a new medical director who will be starting in September, who will be a DPH employee, and I think that position was held by a contractor for like the last 5 years, and we were able to recruit and hire someone under DPH to lead the team. Also just hired a new nurse practitioner who's set to start in about 3 weeks with the team. So significant improvements, but definitely we have a little ways to go, but I think we're doing better with stabilizing our staffing on the corrections medicine side as well.
That sounds good. Is there a designate who should kind of provide regular updates to the board on the corrections medicine side?
Yeah, so some changes with that. So I just also forgot about this. I just also hired a new COO who starts in 3 weeks also. So give me a little time, but that COO will be the person who can provide those staffing updates. So I'm sorry, I forgot to mention the new COO position. So yes, I will have someone, but just give me some grace to be able to get her trained up, but she will be the person who will be able to provide accurate staffing updates if that's what you all would like.
Yeah, certainly. That would be great. Sounds like you've been doing a lot of work staffing up in your kind of senior team. So that's good to hear. I like, when we were hearing, a year ago, some of the rates that the contract services were requesting, or that the kind of the market rates, those were kind of shocking and seemed to be pretty clearly unsustainable. So the big picture strategic direction that you talk about of bringing as much as you can in-house certainly seems to be, the fiscally responsible and sustainable approach. So that's good to hear. Alex, you probably may want to weigh in.
Yeah, I just wanted to commend Dr. Cunningham for doing a great job with recruiting staff to fill those positions. It's well known in the healthcare industry that there is a shortage of particularly nursing, but across the board there's a shortage of healthcare providers, and so it makes it I think especially challenging for the position that Dr. Cunningham is in. So I just want to again commend her for all of the hard work and getting people on board. I think this is going to be a really great for the patients and for the people in justice services. Thank you.
Thank you, Dr. Garza.
Thank you. You also mentioned staffing up in like the medication assisted treatment area, which is just given kind of the things I read and the things I hear from people who are friends who are working in reentry. It just seems like the scourge continues to worsen. Are we seeing just a continued elevated percentage of people coming into the facility with drugs in their system?
I don't know how much I can speak to the exact that question, but I will say this. I've definitely improved our intake screening process. I think before we were not capturing all of those entering into intake. So my MAT team, they meet weekly, and we are intentionally focusing on revamping and improving that program. So we have one aspect of how can we increase screening at intake. So that's one different plan, because sometimes people do leave faster than, within 48 hours, or they're still down, in the intake area. But how can we capture and make sure if they leave us beforehand that we still can connect them to care and resources in the community? So increased screening, and then there's like a triage system where connection to community resources are, starting on treatment inside the jail before they get up to general population. So that is one thing that we are identifying more individuals, but I think that's because we've done a good job with screening that intake. Additionally, definitely making some changes to the team to streamline how we start buprenorphine. And we also have Sublocade that we're added on formulary as well. So we have access to all the different forms of treatment. So if someone comes in on methadone, that's one thing. If someone wants to start buprenorphine, or we switch to Sublocade, we now have access to be able to be flexible with which treatment that we start and how our teams rank. And we also give priority with those who do need treatment, that we kind of classify them under the, expedited appointment that's needed with the provider. So that way we can get them in much faster for assessment, evals, and things like that. So one focus, really focusing on building this team, and then just revamping how we do screening, intake, access to care. And then the other component of that is making sure that we can connect individuals to continue treatment resources, wraparound resources once they leave. So that's what we're focusing on, 3 different aspects with the jail right now. So all of that, doing a better job, but definitely I do suspect over the next coming weeks or so, as we're continuing to improve this program, that we will have more people on treatment and be able to connect more people with community partners to continue treatment, so they're not lost in care. And that's where the CHWs come in, as well as the MAT discharge planner that will go on with individuals. One other thing that Scott and myself—
CHW, is that community health worker?
Yep, community health. Yeah, we have 3 right now that's embedded in the jail. So that's going to be huge to be able to have CHWs make those appointments or call and see who have available spots. But that is something that I think that's key to assisting individuals to continue treatment even after they leave the jail. So those are a few things. I do suspect that that program will continue to get stronger at the jail.
That's all really good to hear. And I especially appreciate kind of the attention to what's happening downstream, like after their, and I'm wondering, like, what kind of tracking will the community health workers be doing of like mid to longer term outcomes for people? Like, I'm just interested in like, if we are creating a body of data on outcomes, A, so we can obviously see how we're doing, and B, so that maybe because communities, counties all over the state are struggling with this. And I know from just dealing with people at the state legislative level that some counties are resistant, some authorities in some other parts of the state are resistant to MAT. I would just love if we can show success to be a model for, other parts of the state.
Yeah, I am right with you. I mean, thankfully, we are in a city that a lot of us are. There's a significant group of individuals who do a lot of work in this space, and so I think for me this is a priority. So I came in with making this a priority for not the correct team, but also just my public health teams. I think that's one thing. Leadership establishes as a priority. It's easier to get people to start focusing and on how we address this and how we develop the program. So in St. Louis region, at least, I know there's a lot of support for both city and county to be able to strengthen our substance use services. As far as with outcomes, and I will say we don't track, we'll track, who's connected to care, but then we don't continue to track beyond that. If they stay on treatment 6 months, 12 months, I mean, we can probably get to that, but right now we just don't have the staff capacity. I think my main priority focus is connection to care access is inside the jail, and then make sure that we connect individuals and work with community partners to continue that care. So there's a lot of work that needs to be done. I think we've done a lot with my time being here, but I can definitely see where we can go in the future with this. But I'm just thankful that here locally, there's so much support in the community to work with the jail, that just makes it even better that people can prioritize people leaving the jail as, getting appointments sooner. So we have that type of relationship, which I think is key for individuals leaving a jail to decrease their risk of overdose or return to use or, X, Y, and Z. So I'm hopeful that we'll have a stronger program, but currently working on that, and I hope to get there.
Thanks so much. That's all great to hear. Really informative, and look forward to future updates on it, on how it's going.
Perfect.
All right.
Hey, Jeff.
Yes,
Yeah, I had a question on staffing, if you don't mind.
sure.
Tremendous report, and I'm kind of going down a different route now. My question is, are there any chaplains on staff?
So we have a volunteer chaplain, Ted Winters, that's been with the jail for 30 years. And we do have many chaplains that come in as volunteers. There's over 200 volunteers, a lot of faith-based programming, but currently not a paid chaplain on staff.
Is it possible to look into that? Because, I mean, obviously being a preacher, that's a concern. But when it comes to emotional well-being, mental health, I believe that spiritual component is a part of the solution. So what's the possibility of that, hiring somebody full-time to oversee that?
We could definitely look at the possibility of doing that. And Ted has actually been full-time as a volunteer in the jail for many years. So I don't want to understate that our commitment to that and the work that he does. He just has said that he didn't need to be paid for all those years of service that he's wanting to volunteer. So that's a real blessing for that we have, and he has been behind the Easter services and the concert that was held this Easter, and then the Christmas concert that was held last Christmas, and also in developing our transitional housing program, where about 40 area churches sponsor releasees and help provide transitional housing and a one-on-one faith-based mentor for them. So we're doing some very innovative things there, but I do understand that we can't always depend on volunteers, and we're fortunate to have so many, but budgets are always kind of challenging as well. So I will take your recommendation and go back and try to determine if that's something that we could move forward with.
Thanks, and I definitely understand that. If you could kind of flesh it out for me, say a resident is dealing with an emotional situation, perhaps the loss of a loved one, perhaps trying to overcome the drug addiction, and they just say, "Hey, I need someone to talk to right now." So is the chaplain available for them, or how does that work when it comes to the individual residents?
Yeah, I think right now we have about 15 different people coming into the jail that are working with Ted from area churches. And I'll give you a full listing of those. I can share that with the board so you have a better idea. But we also have case managers on every floor that are communicating with residents. The Department of Public Health has behavioral health counselors that respond. We have People's Health Center that are coming into the jail. We have behavioral health response that are working at intake to identify people with needs and helping assess them. And then we have the integrated health network that also has staff inside the jail. So we are responding to those right away. Where our corrections officers do an excellent job of identifying people that might have a need there as well. So I'll get you more details on a day-to-day basis how those volunteers are coming in and doing that now.
Okay, thank you, sir. And if you ever need a connection like with clergy that has the certification, you know, the education along with all of the certification that they need to assist, let me know. I'll be glad to be a resource for that. Thank you so much.
Okay, great.
All right. Unless there's anything else on staffing, then
This,
I'd love to
I do want to go ahead and mention, some of you may have not met Nate Hayward, our new Deputy Director of Security. He's at the meeting today.
Hello.
Hey, Nate.
How you doing today, Doc?
Good to see you.
Yeah, same here.
So we also have Brent Curitan as our new Superintendent of Security. And so those positions have been filled. We have not filled our Superintendent of Community Corrections at this point. We're waiting on the budget to see.
Nate's former job.
Yes.
Yeah.
And then our next item on the agenda is the Crisis Intervention Team training. And so we have an opportunity now to have almost 40 officers trained in this. This CIT is a training that police departments, law enforcement agencies have been using to help identify people with mental health needs, de-escalate situations, and help in their response. And so Missouri actually is the only state that has a statewide CIT database that now, and it was created by St. Louis County, actually. And so we have been given access to this system. We'll have people trained so that they can, when a person is coming into the jail on the front end, we'll be able to see what contact there has been in the community, which will help us in our assessment of their needs, whether they might be appropriate for the mental health unit, and assist us in our response with those people. And then on the back end, we'll be able to enter information into that database. It won't be healthcare or medical information due to HIPAA regulations. It's centered more around the law enforcement side, the contact and communication, but that will also help law enforcement in the community know that this is someone that has mental health needs and help in their response. So I think this is a great opportunity. And while we're the only one now, I think it's more likely to say we're the first, because I do anticipate that this will be very successful and spread to other jurisdictions.
Certainly sounds like something from which the city could benefit.
Definitely, yeah.
Given the situations, you know, the challenges of the last couple of years at the city jail. All right. Thanks for sharing that. Any questions on the CIT training? Okay. Why don't we go to the dashboard? Aaron, hope you're doing well. Been a while.
Yeah, thank you. Good to see you all again.
Yeah.
Trying to get this one. There we go. Okay. So we have kind of a mixed bag of updates this month. As you all, if you've been looking at the dashboard, as you all are probably aware, we've been having our population increase. As of today, we're at 1,005. We've been hovering probably between, I'll zoom in on this, we've been hovering probably between the mid 900s and 1,000 the last 3 months or so. So that's we've been trying to address that in our PRT meetings, our weekly meetings, but it is what it is.
Aaron?
Yep.
Do you typically get a seasonal increase when it gets really hot and tempers rise?
Yes, that does happen, though not in a like a totally predictable way. Like you know, you'll see like in 2021 and 2022, there's like, you know, well, this 2021 was different because we had the cancellation of the federal contract here, which caused the big decline in the summer. We had a slight increase in September, in 2022, there was no increase. It went down the whole year. So that does happen. It happens some years. It doesn't happen every year.
Okay.
I mean, I've heard about it happening in prior years, so I know it does, but it's not a guarantee. I guess I'll put it that way. So on a more positive note, we are way down in use of force this month. Actually, the lowest number we've been in quite a while. Barely any uses of force at all in June, which was good. The other thing I wanted to mention, we don't have to get too much into this, but I wanted to look at this chart a little bit. So this one shows basically each month it averages out the classification types for each of the groups. So this is the total. The top is the total number of people who are pretrial in the jail in a given month, and these are averages across the month. And then that's parsed out into A felonies, B felonies, unclassified C, D, and E, and then non-felonies. So not surprisingly, most of the people who are here in the jail pretrial are felonies. But the thing that I wanted to mention is that we've seen a slight change in the composition over the past 4 or 5 months. If you look at where we were, like at the end of, well, let's say like at the end of, let's say more like 6 to 7 months, at the end of 2022, since our population has gone up, the high level felonies, which are A, B, and unclassified, if you look at the total height of the bar, it's only kind of gone up slightly. It's not too different. But if you look at the total height of the combined C, D, E, and non-felony bar, that amount has gone up substantially. So what we've seen is we've seen a disproportionate increase in the low level people in the jail, which has led the percentage of C, D, and E felonies to be higher than it was 6 or 7 months ago.
And that seems like something that the PRT could grapple with.
Yeah, we work on it. When we're aware of the fact that that's been going up. I know that in 2 months, the percentage of CD&E felonies in the jail went from 24 to 29, and we're aware of it. And I mean, I know that even, Beth Hubner was talking about adding extra sessions to try to address as many of these cases as we can.
Okay, thank you.
And yeah, so and we've let the prosecuting attorney's office know about it as well. And Andrea in the prosecuting attorney's office is certainly receptive to that. So she, we and other partners know that this has been a change, and we're certainly looking to address it any way we can. Let me go to the supplemental dashboard, and then I'll take questions. So our overtime hours worked this month was about 4,900, which is a little higher than it was last month, but still overall lower than it was for most of 2021 and 2022. So
and that should continue to decline.
Yeah, it's been, if you look since early 2021, since May, it is on a pretty significant downward path. So with some ups and downs, of course, but it's hopeful that will continue to decline too. This is kind of a mixed bag. So our resident to corrections officer ratio, actually, even though we had an increase in population over the course of the month, the ratio went down because the number of open positions went down. As Scott was talking about, we're continuing to address the open positions. So the number of correctional officers went up, which meant that the overall resident to corrections ratio went down, even though the overall population number went up. However, we are still higher than we were a year or two ago. We returned to normal on the hospital post. There was a couple months where we had a kind of a freakishly large number of those, but those have stabilized. Yeah. I think that is all of the major updates I have on the Justice Services dashboard, so I'm happy to entertain any questions.
Are the ER runs, is that mostly drug related?
I don't know. It looks like last month was really high. This month, a little high compared to average, but that's it's still returning to closer to normal. So I don't know. It could return to normal next month, but I don't actually know the specifics of the each ER run incident. I just have the total number.
Dr. Cunningham or Scott, do you guys have a sense of that?
I would say I don't. I have to look into that. I mean, I was aware of a few ER cases, but I'll have to see with that significant jump what took place. I don't have anything to share right now, and I wouldn't want to misspeak or lead anyone in the wrong direction.
Yeah, it is worth noting that this is a pretty low frequency event. So, if there's a increase of 5 to 10 in a month,
Right.
You're going to see the number go way up
Right.
because the base is so low. So that, I'm not saying that it is not an insignificant increase. If we may want to look into it, but it's certainly easy to have mathematical noise within that variable too.
Yeah, 5 to 25 over 2 months is
That's
pretty
right. Yeah.
significant.
Yep.
We
Um,
also, Jeff, we also prefer that they be taken there if they need to be. So we're fortunate to have an infirmary that most jails don't have, where medical staff can provide much more care than normally a jail would provide. But we do want them to go to the emergency room if necessary. And so you have a jail with people coming in, and as we've talked about on some of the past meetings, people coming in. Some of them don't even come into jail initially because they're not fit for confinement, and they have to go to the hospital where they may stay. If a person gets shot, they may stay there for a month, and that's happened, or even longer. And so we want to make sure that if a person needs to go there to be stabilized, that's happened. And so I do think that Aaron's correct, and that if you only had 2 and now you have 4, that's 100% increase, but the number is still very low.
I'll also add, Scott, while you were talking, I'm just wondering, I know I have a nurse intake manager down there, and yes, the population increased, and I wonder where we're capturing more. I don't know if this number is, like you said, if it's those being sent out for fit for confinement, or if these are truly those that's already in general population or infirmary, or if it's a combination of all of that. So, and it could be with increased population and, trying to identify if someone is fit to go inside. That could have been where we captured a few more, where the medical team erred on the side of sending someone to the ED to make sure they were fit to come into the jail. I'm just not sure, but I think all of those are possibilities of why we see a slight increase.
okay, do you want to go? Yeah. Anything else, Aaron?
Oh, actually, I did forget to mention one thing. This is a little bit of an odd quirk. So I don't usually look at age that much because it's relatively constant. It tends to sneak up slowly over time as the average, US population age increases. But we have seen, this is interesting, the average age in the jail has dropped by 0.7 of a year over the past 4 months. I'm not sure why on average we're getting younger bookings, but for a field that doesn't move a lot and generally moves very slowly, I should say, it takes a long time to move. I found that to be a little bit interesting. I'm not exactly sure. I can't explain why, but it was an interesting quirk, and I'll keep an eye on it. So I don't have, I think that's it for important updates on the Justice Services dashboard. I did not notice any real changes of substance on the medical dashboards. There were some fluctuations, but I didn't notice anything that looked like like an abrupt change. I just got that data yesterday, so I updated that yesterday on the dashboard. It's available to see. I can go to it if you'd like, but I did not notice anything particularly substantial.
You want to just pop it up super quick?
Sure. Oh, I think this is the second. Okay. Number of persons with safety events still hovering in the same range. Percentage of open corrections medicine positions is about in the mid-20s where it's been the last few months.
Aaron, do you want to talk a little bit about the bond amounts, the cash only bonds?
Sure. So this is primarily just for the low level felonies because that's where most of where I keep the data on. So Scott, do you want me to talk just generally about the high number of cash only and no 10% bonds?
Yeah, because that's really behind what the population increase is.
Sure. So as we mentioned a few minutes ago, just to give a little bit of background, the population increase, although can I go back to if there's no questions on the medical dashboard, can I go back to the main dashboard, Jeff?
Yes.
Okay. So the population increase, as we talked about, has been largely generated by low-level felonies. And in fact, in the course of looking at PRT data this week, I noticed that I think it was over the past 2 months, the increase in low-level felonies has actually been bigger than the overall increase in the jail population. So it's accounting for right now, over the past couple months, actually more than 100% of the total increase in the jail population. So as Scott just mentioned, one of the things that we see among the low-level felony population is a very high proliferation of people who are given high dollar amount bonds with provisions that it can only be paid in cash with no 10% option allowed. And so we've been seeing on these CD&E felony cases a ton of people who are in on things like more minor gun charges or drug charges or resisting arrest, coming in with $100,000 bond, cash only, no 10%. And, for most people, that's a completely unpayable, unworkable bond amount. So the jail population increase has been super concentrated within that low-level felony group lately. And we believe that one of the reasons the low-level felony group is increasing at a rate so much higher than the rest of the jail is because we've seen a pretty substantial increase in bond conditions over the past 6 to 8 months.
Okay, this is all helpful and informative. Does anyone have any questions on anything related to either the security or corrections medicine dashboards?
Not at this time, Jeff.
Good to see the use of force being at a pretty historic low, it looks like, at least in the last
3 months have all been really low. I mean, these are all,
Can you
under
Aaron?
25 per 1,000.
Can you go back to that previous slide you were showing where you can see the population increase along? Oh, I'm sorry, all of them all together. There you go.
Do you
So
want
if you look
this
at
one,
daily
Scott?
right? If you look at daily population, and you can see the increase since January of 2023, and go back to the other one.
Yeah.
Yeah, so since 2023,
Yeah, I
and
just want to
then-
show them together, Aaron.
Yeah,
So
you're going
went too far.
Oh,
Hey,
you're
you're-
saying just these two. I can't
you're going
show
up.
two at the same
Ju-
time.
Just leave
Yeah,
it.
you
Yeah.
don't need to
leave it-
show two. It just shows that we've gone up 300 people, but the number of uses of force has gone down dramatically in the time that we've got 300 additional people, which is a pretty good juxtaposition, pretty good contrast.
Right. If you look at daily population and then look directly below it while they're both together there, you can see since January of 2023, they're inversely related.
Which is, again, would seem to be counterintuitive because, you think the more crowded it is, the more potentially, the more potential disturbances amongst detainees and then vis-a-vis COs as well. And we're seeing the opposite, which, you know, hopefully is a testament to all the training you're doing and the de-escalation work you're doing and just the continued change in the culture of the facility. So that's really good news.
Yeah,
Thanks, Scott.
yeah, thanks, Jeff. Yeah, we have staff are working very hard, and the makeup of the population is the same, and we have a lot of new staff, and so it's a really good indicator of the progress that's being made.
Well, thanks for flagging that for us, Scott. Aaron, as always, thank you for compiling all this data, which is really helpful for us to be able to pinpoint, you know, things that are going on and things we want to dig deeper on. I would be interested in did you have, we don't have a specific thing that we see every month for the percentage of people coming in that have drugs in their system, do we?
We don't have something on the dashboard for that. However, I do keep a record on the number of people who are currently in the jail who are in on drug charges. I don't know about drugs in their system though.
Since that's like a collective thing and we're not looking at any individuals, would it be possible to get that data?
I don't actually know. I'm not sure. Scott, do you know how our data capacity is on tracking people who come into the jail with drugs in their system? Oh,
You're muted, Scott.
I think I believe that the Department of Public Health would be the ones that would keep those records
okay.
because we're not administering those tests. Dr. Cunningham might have more information about what's available.
That also could be something that we put on the prospective. At some point in the future, we're going to change the medical dashboards to track all new things on there. But it's been a process, so it may not be for a while. But yeah, if anybody from corrections medicine wants to pitch in, they're welcome.
Yeah, we're just about done.
Yeah, I also just wanted to add that it seems like we've lost the internet in the office, so we're able to continue our meeting. But about 85% of the people in the jail are awaiting trial, not yet convicted, and 75% of them are going back to the community, and that's why these programs that we have are so important. And seeing the population increase, we're meeting with the judges soon in just a week or so to reemphasize the availability of alternative to incarceration programs like the mental health court, drug court, veterans court, choices, residential drug abuse program, our GPS monitoring program that we've created, and our transitional housing clergy bond program that we have established. So hopefully we'll begin to see some of those bond levels reduce. But in the interim, we're continuing to increase the number of staff that we have so that we can continue those important programs and initiatives that we have.
And I thought it was positive this month that even though the jail population went up, the overall ratio of staff to residents went down. That's a testament to the overall number of staff going up.
Yes, definitely.
Absolutely. Well, thank you very much, Aaron, for that presentation, and look forward to seeing you next month.
Yep.
Penny, is there any public comment? I think that
I think they just lost internet again.
I think they lost internet, and I don't believe there was public comment. the county counselor's office just suggested that we adjourn, which I think makes sense, especially since we're pretty much at the end of our agenda. So next board meeting is scheduled for August 25th, I believe. Yeah, August 25th. So I will see you guys on August 25th, if not before. And maybe I will try to make it up. I can't make it up at 1 o'clock because I got to take my kid to camp, Scott, for that graduation. But if anybody wants to, maybe I'll try to get there on the late side to see that, because I would love to see that degree award. So I'll see if I can get over there, if I can figure out a way to get rid of my other kid. And get my one kid where they need to be. So thanks
Well,
everybody for your
we'll have a lot more, Jeff, if you can. So.
Okay. Thanks for the invite. As always, please keep us apprised of like interesting things to come to. I reached out to everybody about the deal last week, and I'm sorry everybody had conflicts, but let us know with as much advance notice as you can, and we'll try to get to some of those things. Okay, Scott? I love
Okay,
going
great.
to them.
All right. Thanks, Jeff.
Okay, guys, stay cool out there. See ya.